we have a special meeting for Government of India looking at health and family welfare, initial disease, and whom you all are always to be in track. It's very kind to be here to share his views. So, over to you.
Dr. Gupta, my colleagues, Professor Kumar, and friends. I missed Dr. Kumar's full presentation, but from what I heard, he has placed before you a very clear sense of the tasks ahead and of the very wide dimensions of public health. I think he correctly focused on the fact that while we may have begun in independent India working with infectious disease, and almost only infectious disease, that today we are looking at a situation where we continue to battle infectious disease. Maternal and child health continues to be unacceptably high in many states, and of course the threat of non-communicable disease. These are well-known facts, but I think they need to be reiterated again and again. There are three broad issues that I would just like to throw into this discussion in the context of everything that has been going on. There has been much excited reporting in the newspapers about, the perceived dispute between the Ministry of Health and the Planning Commission. I think rather more was made of this matter than actually existed. For the reason that, given the scale of the resources that are needed if we are to provide universal access, and if we are to provide universal coverage on the basis of universal access, it is clear that resources, whether public or private, will all need to be drawn into this process. It is nobody's claim that public resources alone will be enough to meet the requirements of what we will need to do to provide universal coverage. It is also true that the capacity to spend in the public sector is limited by the number of people available. It would be wrong to think that we have, even at this point in time, the ability to spend. Dr. Ashok Kumar mentioned the figure of 400,000 crores is what we've asked for in the 12th plan. That is indeed true. I'm not actually sure if we will get that amount, but I think it is safe to say that we will get more than we can easily muster the ability to spend. So for the question of resources, I think it's quite clear that we need public and private resources and the ability to spend both in the public sector and the private sector. This leads us to the next question of what is the perceived apprehension? Because very rapidly people begin talking about privatization of healthcare. Now, experiences with privatization from elsewhere in the world have not been very inspiring. The answer to this really lies in the fact that if you have unregulated privatization, then it's quite possible to no control over the outcomes. And given that our ultimate objective should be the provision of healthcare to a very large number of people who probably cannot afford to pay anything. So, this is a difficult question of what is the kind of regulation that we are talking about, that we need, that will enable a proper delivery of healthcare services at the delivery point in such a way that the health and other interests of people are not affected. And this is where the doubts come in, that maybe we are not in a position to enforce a regulatory mechanism over services. Medical Establishments Act has certainly been introduced. Only a few states have adopted. We are not in a position to make that the basis of nationwide reform. The Medical Council of India is indeed expected to play a regulatory role in the business of the conduct of practice. But that again is not a very happy process. We're aware of it. So the great doubt that comes up in the matter of outsourcing services to the private sector is the fear that this will end up, the citizen will end up paying more for the services than now. The example is always given of the National Health Service in the United Kingdom and the system of which the entire country is broken up into, is divided among general practitioners who have a designated practice. But that is a superbly regulated system. So while every single GP on the rolls of the NHS is a private practitioner, not a government servant, with the government facilities only being a few great public hospitals, the system is able to ensure a very detailed and rigorous regulation of the practice. The General Medical Council, which is vastly better resourced than the Medical Council of India, is in a position to enforce the highest standards of service and clinical performance amongst doctors who have signed on to the NHS. So it is not as though a GP who is on the NHS is receiving large sums of money and performing no service. Not at all. When we will be able to reach that degree of regulatory stability is an open question. Another big issue that needs reflection is this whole question of public-private partnerships, and we have some extraordinarily good examples of this. Emergency transportation under the 108 system, for instance, is, I think, a very fine example of public-private partnership where you have entirely public investment. These are 100% funded by government, but the responsibility for management and running of the system is that of a private party. And so far, at least, I mean, the experience is not more than maybe 6 or 7 years in Andhra and fewer than that in other states. There is sufficient amount of data. I suppose more rigorous analysis will be needed. But this analysis will need to be careful because you will have to compare costs against life saved in a certain manner. So the fact remains that this has demonstrated that it is possible in the Indian context to have working arrangements where government pays the costs, the capital costs, and operational costs, and the private sector provides the managerial ability and the drive and the motivation, and indeed the software that backs that whole system. Another very good example of public-private partnership in the health sector is the great eye care centers in South India. So whether you are talking about Aravind in Madurai or Eli Prasad in Hyderabad or Shankar Netrani in Chennai, these are great public institutions performing private institutions performing a public purpose. I suspect this works because the economics of eye care is such that very large numbers of people come in for relatively inexpensive treatment, and it's the economies of scale that make these function as well as they do. But there is also a substantial element of high degree of motivation, high degree of commitment and passion that makes these institutions function as well as they do. But they are an example of private partners working very closely with the national healthcare programs. So that lesson is clearly made. These things work. These things can be made to work in India, but clearly they need an appropriate balance of motivation and integrity, of regulation, of an understanding of the nature of partnership. These are important, and we need to we need to be careful about that. All of you as senior industry representatives, I mean, one area which concerns you directly is medical equipment is a sector that clearly needs to grow much faster than it is growing. I'm told, and you correct me if I'm wrong, I'm told that cancer hospitals around the country, the kind of radiation therapy equipment they need is entirely imported. Now, this, just by way of example, this is clearly something that we should do something about. I do not believe that we lack the ability to put the technology together. There must be some reason why. This is just one example. There could be others. There is certainly an argument to be made for the big industrial houses, the big health equipment manufacturing industries, to see what more needs to be done, because there is a huge demand for such products in the government hospitals and nowhere else. This needs some work. We need to know which are the growing areas, where are the bulk of these things, which are the areas where most of the equipment is being imported. As I said, I'm told cancer care is one, but there may well be others. There are plenty of others. If there is import of equipment being done, and you see, this generates a further view that no, the imported equipment is always better. That is not necessarily so. Imported equipment is not necessarily always better. We have to demonstrate that this is not. I think those of you who work in this sector need to address this particular aspect. The other big issue that concerns all of you is drugs and pharmaceuticals. As you all know, the government is now committed to free provision of drugs and medicines and other requirements at all government facilities. The Prime Minister said so in his Independence Day speech. This is in the Planning Commission document also says. Now there are issues of manufacture, availability, quality, supply. These are issues where government and industry need to work very closely together. If we are to mean what we say, if we are to ensure that every primary health center has everything on the essential drug list, and that it is a seamless process by which stocks are maintained and distribution made. This needs a lot of coordination, it needs partnership. It is not something that can be done on a standalone basis. And the last thing I want to say, which is something where we need to talk to representatives as to how this particular problem can be addressed. Ashok Kumar mentioned it in the course of this talk, is that whatever we attempt to do in providing healthcare in India, we are hampered for the want of qualified, trained people. Now, whether it is doctors and super specialists, whether it is midwives and multipurpose health workers, there is a shortage at every level. Where they do exist, the quality of training probably leaves a lot to be desired. Now, government is aware of this. There is a skill development council, there's a skills development council that has been set up. I know that several of the people here are part of the CII's own skills development activities. There are a very, very wide range of healthcare related positions that need to be manned by adequately, competently trained persons. This is not easy. This is not easy, and part of the reason this is not easy is because our school system is not good. The quality of people passing out of school, by and large, while it's not as good as we would like it to be, so the kind of people entering the world of work, training probably needs to compensate for a lot of the missed out at the school stage. But still, it can be done, it needs to be done. So, right now, this is not an area that we address very systematically. Let us also remember that by and large, this is a state government responsibility. Making sure that all sub-centers, family health centers, community health centers, district hospitals are fully staffed at all times to handle the whole range of diseases that we now know they have to do. I'm sure Dr. Reddy will speak about the whole question of training for public health. But this is an area where we need to do work, and where, let me be honest and say, our experience of working with the private sector has not been great. I mean, Dr. Ashok Kumar did say that more than 50% of medical colleges in India are now private, which is very good. But the brutal fact is that no one who graduates from a private medical college is available for public service. This is not happening. If a student has to repay whatever loans he has taken, he or she has taken to pay fees in a private college, that person is not going to work for government. I mean, there is no getting away from this. So while it is at one level, it goes to that private resources are going into medical education, and we are creating, as we said, we have 42,000 MBBS places every year. At one level, my only concern is how many of these 42,000 are available to me. Let me also be honest about something else. This is not necessarily a problem only with private medical colleges. There are many government institutions also. An example that I'm always fond of giving is we have in the government sector the All India Institute of Speech and Hearing in Mysore. It's an outstanding institution. But 95% of their graduating class every year is either in New Zealand or the United States, because we do not have posts in our state government for the various categories of speech and hearing trained professionals which this institute is providing. So we have high quality training, world class training, plenty of students willing to join this program who do a rigorous 4.5, 5 year speech and hearing related training program, who are snapped up immediately as soon as they graduate. Or we are now able to provide for these people in state governments. They should be working in district hospitals. But they are not, because we in government have not, we in the central government say that, well, why should we fund this position? It's a state government job. The state government says we don't have any money, why should we do it? So in that sense, NRHM, the National Rural Health Mission, was extremely important in that at least it provided for contractual appointments. So what we, in the 7 years in 2005, we've seen this huge rush of people into the primary health sector. But now, 7 years down the line, people are beginning to ask, what about my future? How long do you expect me to be a contractual employee? When am I going to get a job? When am I going to improve myself? When am I going to get a better position in the health sector? So those, inevitably, we will need to answer those questions. Now, I think where we seek your help in this matter is in improving and upgrading the quality of training, in improving and upgrading teaching methods, better and more imaginative ways of deploying persons who are trained. I think we have to reconcile ourselves to the fact that it's going to be very difficult to get people to physically locate themselves and work in a remote or rural area. This was not a problem through the 50s and 60s, but that was 50 years ago. It is a very serious problem. And certainly nobody who is adequately or competently trained wants to go anywhere. So, but we cannot equally abandon the remote areas to just those persons who are willing to go there, irrespective of what they mean or who they are. So where is there a role for technology? There is a role for technology. What is it? How best can it be made to work? And most importantly, who will be responsible? And this whole debate with the Planning Commission ultimately just boils down to this. It's all very well if you are able to bring in private resources, but who is responsible? But I think the answer to that question I think is also clear. It is the government that has to be responsible. It is and has to be, certainly at this point of our existence, it has to be government which is responsible. But whether in exercising this responsibility, they are willing to use resources, expertise, experience, fund, aptitude, ability of a much wider sector than we currently work with, that I think is a big question that we need to try and answer.